Good morning. It's great to be here again. I appreciate the invitation from David. What I like most about this conference, and I was here 2 years ago, was everybody here is volunteer, and you're here because you want to be. And it's very impressive to see the work that's gone on with the First Responder Network, how it's integrated with the National Ambulance Service, and how it continues to grow. So this is the title of my slides, but reality, I've been asked to talk about the American election, okay? And I don't really know what to say. I am an Irish citizen. This passport, now I have to tell you, you're not allowed to smile for a passport photo. I knew that, but I got my picture rejected from the Irish Embassy in New York because apparently, and there's a checkoff box, I was showing teeth. So I made sure that this extra picture would actually qualify, but this is really backup for this. You gotta have a plan B. And I know we're talking, I'll probably get some questions later. All I can say is I think people outside the, time is up. Okay, we're done. I don't know what to say, honestly. It's 24-hour reality TV, but it's a little scary. So what I'm really gonna talk more about is cardiac arrest globally. Obviously, a lot of discussion this morning about disease specific to Ireland, but obviously it's not a condition that's just unique to Ireland or Europe, the US. Arguably the leading cause of death, cardiovascular disease in the world. Not that long ago, infectious disease would have been considered the top killer. Through changing economies and changing diet, there's a lot more burden of cardiac disease relative to other conditions, and the leading cause of death, particularly in those folks greater than age 40. There's obviously disparity. Certain countries estimate about 60% of the global burden is in underdeveloped communities. So there's a lot of opportunity, for improvement. And the idea of measuring this condition, obviously the discussion earlier this morning about OCAR, you have a registry, and that's great. The U.S. registry or CARES that I've been involved with, we're still only working with a third of the U.S. 2/3 are not on board yet. The idea that you've got a measurement tool, this is really caught on globally. Registry and the Eureka registry in Europe, which is the first attempt at trying to get common taxonomy, as well as in Asia, apparel, so I'll talk a little bit about that. And the idea of measuring to improve. If you don't know how you're doing, it's really hard to improve upon, sort of having a report card. If you don't have a report card, you don't know where you stand, and it's really a first step. So we've known for a while what matters, and the first 3 links in the chain of survival is really where the impact is. That initial call and recognition, dispatcher piece, first responder, or hopefully layperson starting CPR, and early defibrillation. That's really where the bang for the buck is. Obviously, the entire system, the care that occurs after, the professional care in the ambulance as well as in the hospital, all matter as well. But when you look at data that's more than a decade old, we've known this for a while. It's not new news. The idea of measuring, benchmarking, and feedback. This morning there was discussion about what's appropriate feedback, in terms of debriefing. I think it's an excellent question. The idea that we have to understand how can we improve on the next event. And really that goes back to measurement and comparison. You've seen this slide already. It's not, unfamiliar. Each of these steps we really need to kind of drill down and see how we're doing. There's always an opportunity to improve, and obviously data is sort of the first step in that process. Not that long ago, in June of this year, in the U.S. Committee or Institute of Medicine, which really makes recommendations to Congress, though Congress sometimes has challenging implementing laws, as you probably see, they've made recommendations about cardiac arrest. 7 or 8 main recommendations. Their first main recommendation is that there be a national registry in the U.S., again, focusing on measurement. And the slide here really kind of highlights, I would point out a lot of things that are important, but the foundation is recognizing comprehensive surveillance and reporting. The first floor is continuous quality improvement, and the roof is obviously trying to improve outcomes. All of these things in between the steps and the pillars are equally as important, but focusing on the basic foundation, first floor, and roof really are focused on measuring and improving. I'm going to really quickly go through, these are the 10 things I think that are most important, and try to do it with as many pictures as possible. The idea, in my own opinion, 10 things that are really important to measure. You can drill down in each of these and think of a lot of other sub-metrics, so to speak, but the idea of who's actually collecting data or participation, the telephone CPR or telecommunicator CPR, collecting data on that and doing quality improvement, actual CPR metrics. You've heard this morning in terms of the PHECC approach, how well the professional response is. Obviously the hospital care, patients that qualify for emergent reperfusion therapy and targeted temperature management. At the neighborhood level, we know in certain communities no one's doing CPR, how we can drill down and try to look at opportunities to target training. Public access defibrillation, very important as John talked about this morning. And then looking for where there's opportunities for disparity in care. We'll show you data there where we understand that certain communities there's a greater need, benchmarking, and really trending data over time. So I'm going to guess somebody probably knows where this picture was taken. Any ideas? There you go. And this was, I was in Ireland here in May. Beautiful weather. I was a little surprised when it was snowing, landing on Friday. And the pilot said that. I said, snow. Okay. I don't think that happens often. But the idea that in Ireland you have a pretty good idea. You are collecting data throughout the country. Other registries, as I mentioned, PEROS, this is the Pan-Asian registry. They're working with several countries and other countries that are trying to come on board. Some countries it's just certain cities, but the idea that they're globally trying to collect data, same data elements, same benchmarking process, and really using it as a starting tool to improve care. In the US, this is our footprint for CARES. We just brought on a coordinator in California. It's a pretty large state this past year, working with hopefully 10 more states this year to get each state to have their own state registry and allowing the 2/3 of the communities that are not collecting data to begin to understand how they're doing and a starting point for improvement. Anybody recognize this slide? I'll give you a hint. It's in Belfast. The late 60s, this was a picture and article on one of really the sort of foundations for emergency cardiac care in Belfast. And Dr. Painridge was really arguably the first team approach of dispatching what looks like a bread truck ambulance with a nurse and a cardiologist to respond to patients that had chest pain. And they brought this device with them called a defibrillator, and every once in a while somebody that had chest pain went into cardiac arrest. They showed with his initial study that there were survivors. So arguably the first mobile coronary care unit, but the idea that these people needed to get to the patient. And this was really a response to a chest pain call that went into a cardiac arrest. Whereas today, we're starting earlier. We're starting that call to really the zero-time dispatcher or zero-time responder, getting the, hopefully, family member or layperson to begin CPR and to recognize that event in advance of the professional responders and first responders getting there. So there's a greater need to start that event sooner. We can't just wait for the professionals to get there because that, even in an urban setting, it's going to take 8 or 10 minutes, best case scenario. The idea that we can do a more formal training process for dispatchers, collecting, doing quality improvement on that process, and really improve so there's a greater likelihood that when someone calls, the event is recognized and there's a minimum amount of delay in terms of gaining control of the caller to providing those instructions. This is a slide from Goa, India, where a dispatcher CPR course was performed. The idea that this is occurring globally, this is with the Pan-Asian or PEROS group. They've done one-day training courses. We thought it'd be a great idea to go outside under the palm trees rather than indoors. But the idea that this is something that can be done in many communities where there is an official, emergency number and training folks that may never have done CPR to get them to do CPR in advance of an emergency response. This is a training course in Japan. The woman who has the headset is actually a trained dispatcher in Tokyo. The gentleman on the phone is actually connected in real time to this box that allows them to talk to each other, to role play, and to simulate her walking him through the event to actually do compressions. So the idea that this is something that should require official training and dedicated training. Why would we think it's any different than someone learning CPR for the first time? This is community-based training in Japan. For those that very dense population, putting an AED in a vending machine. So I'm going to move through. This is to show data that's been a before and after analysis in Singapore when they implemented a dedicated CPR training. They almost doubled bystander CPR in a year in that community. The idea of doing web-based training that can be translated into several languages is another opportunity. I mentioned CPR metrics, collecting the actual data from the professional response, pulling the code summary data, and looking at how well did we do, debriefing. But we can also use that data for research purposes as well. This is looking at 2 years worth of data with CARES and recognizing when we look at pediatric data, about 2,000 cases. You heard this morning about younger patients having this disease, more focus on congenital or genetic predisposition. It may not all be coronary artery disease, particularly in younger patients. The first year of life, we think more of SIDS. The rest of the cases here, are more evenly distributed in adolescents and older. Looking at the benefit of CPR, when we look at that pediatric subset of patients, you can see that it does make a difference. When you tease out the first year of life, there doesn't seem to be as much benefit, likely because most of those arrests are SIDS and they're unwitnessed. The idea that there's even greater benefit when you look at you excluding that first year of life in terms of those adolescent patients that are getting CPR versus those that don't. We recognize too that there's racial differences and again disparity and really understanding where we might put resources and try to target more vulnerable populations, who's getting CPR versus not. And again, this is likely an event that's going to occur either in a public setting or in the home, and there's really an opportunity. Hospital piece I mentioned, I'm not going to spend a lot of time, but targeted temperature management and those patients that are having an ST elevation MI that, that precipitated their cardiac arrest, needing to do emergent reperfusion therapy. These are things that need to be measured at the hospital level. The community level, this is actual data from Hawaii. People have ever been to Waikiki or ever seen Hawaii 5.0? This is downtown Waikiki, and right along the water is where there's a lot of foot traffic. There's also a lot of public arrests. So we're mapping essentially ABC stores is like a 7-Eleven is in Hawaii, and there's a lot of them. They're open 24 hours a day. The question was, could we put AEDs in those stores and try to match where the arrests are occurring? How close are they to those stores? So this is really a first attempt to get a better understanding of, mapping data. This is data in Atlanta looking at where are people doing bystander CPR at the neighborhood level, or what we call census tract. The north part of the county, much greater chance of getting CPR than in the south part of the county. And a lot of this has to do with socioeconomic, relationship. And this is really taking that same data set and multiplying across a larger area. You have a much greater chance of getting bystander CPR in a predominantly Caucasian census tract than African American, about a 50% greater chance, but also higher income census tracts later, less or greater chance of getting CPR as well. So understanding where the opportunities are, this is how mapping can help. Benchmarking, I'm going to just jump ahead here for time. The idea, we tell each community confidentially, how are you doing? How's your tree in the forest? Are you above that red line or below? And really understanding that this is what is the first step to get communities to begin to understand how are they doing and what can they use to strengthen the chain of survival in their community. Trending the data helps as well. And we've shown over time, when we look at all the communities that participate in CARES, over time we've seen improvement in bystander CPR, likely because of a lot of local initiatives. We've also seen an uptick in AED use. This is really not so much so for public access, that blue line, but more medical facilities where we see. And the idea that when we trend our data over time, this upslope and improvement over time represents other registries that have shown sort of the same upward trend. And it's likely from a number of different things. This is Japanese data as well. Different years, but the same idea of an improvement. So to kind of summarize here, we talked through these 10 elements kind of quickly. And it's going to end with, it's a little blurry, but this is, any idea? Yep, Opera House. I happened to be there for a resuscitation conference that was held at an amusement park. That was the first on the other side of the bridge, and there was a light show going on, so it was great pictures. But really the conference was summarized by, keep calm and restart the heart. And I'll leave you with that. I hope that translates well. It's always a little bit concerning if you think Google Translate translated everything correctly, but apparently this was a famous Irish saying, and I believe it. Your health does matter more than your wealth. So thank you again, and have a great conference.